Hello, everyone. How's everyone doing?
Good.
Not well? Yeah, some mixed and muted responses. Yes, hope everyone is taking care of themselves. I think being in public health, we all know we have a lot of work that we can do in the coming years after the election results rolled in. We have our job cut out for us to protect health and well-being of people here in the US and globally, especially minoritized populations. I think it's nice to be here and hearing about important work and trying to ground ourselves in public health and yeah, maybe distract ourselves a little bit. So happy to be here in that regard. I'm gonna introduce Abigail Greenleaf, our speaker today. This is a talk co-sponsored by the Hopkins Population Center. Abigail Greenleaf is currently an assistant professor at the Columbia University Population and Family Planning, excuse me, that's our department, Population and Family Health at the Mailman School of Public Health in Columbia University. She is a public health demographer, and her research focuses on collecting data in low and middle income countries where using cell phones to survey populations is an increasingly viable methodology. Dr. Greenleaf's public health career began by joining the Peace Corps in Cameroon after college, after which she pursued her MPH at Columbia University before working for the CDC as a global health fellow in Ethiopia and Cameroon. And she later obtained her PhD from this department here at Hopkins, which is where we met and overlapped. And she currently works with ICAP's population-based HIV impact assessment, or PHIA, project at Columbia University. And today she's going to be discussing results from her KO1 study on the dynamics of contraceptive use and Eswatini. I'll also plug for people who are meeting people in their cohort right now and folks here at the School of Public Health during their degree program. Look around you, because these are the people that you'll continue to learn from in the years ahead. We are part of a weekly writing accountability group with a few other folks with KO1s, and I'm always impressed by Abba and her work and continue to learn from her. So I'm excited that she's here to tell me more details about her KO1 work that I've just gotten glimpses of over the past year. Welcome, Abba.
Hi, everyone. Thanks for joining. And it's nice to see some familiar faces in the crowd, and it's nice to be back in Baltimore. So I'm talking to you today about HIV protection patterns among a panel of 321 women we have been calling every 2 weeks in Eswatini. So, that's right. Oh, great. There we go. So my presentation is like most presentation outlines, will have background, study design, methods, and I'll be explaining sequence analysis, which is the analytic method I used for this. Has anybody ever done a sequence analysis? I think it's new, mostly not new to public. It's new to public health. Sociologists have been using it for a while, so I'll explain that. Then I'll share my descriptive results, the sequence analysis results, and we'll have time for discussions. So acknowledging now the funder as well as a textbook, which not everyone acknowledges a textbook, but this textbook was excellent. And they also had a full accompaniment of R code, so that for every section of each chapter, there was code so you could make the graphs that they created. So even if you decide you don't want to do a sequence analysis, if you want to visualize data, especially longitudinal data, this is great code. So noting those folks. And then I think it's important to think about who we are and what we bring to the work. So I am not from Eswatini, I'm from Iowa. I'm older than our cohort, so they're 18 to 24 years old, and I'm trained as a demographer in public health. And so of course that shapes the work I'm doing. We have a really strong team in Eswatini we work with, but I always want to acknowledge who I am and what I'm bringing to my analysis. So let's talk about HIV, especially among adolescent girls and young women. So since the onset of the HIV epidemic, young women have been disproportionately impacted by HIV. And the risk of HIV among adolescent girls and young women is primarily driven by age-disparate sex. So after acquiring HIV from same age partners, older men then have sex with younger women. Those younger women have sex with men their age. Those men have sex with younger women, creating a cycle of transmission. So they're disproportionately impacted, and particularly in Southern Africa, you can see in this map, it is a darker red, indicating higher HIV incidence among young women. So what can we do about the ongoing HIV epidemic? We have PrEP, which is pre-exposure prophylaxis for those who are not familiar with PrEP. You can use daily oral PrEP. It's actually worked quite well here in the US, but in sub-Saharan Africa, among young women, it is not that effective. People have a hard time taking that daily pill. It's really wild to see like the first paper on daily oral PrEP in the US and comparing that to the results from like the first study on daily oral PrEP in sub-Saharan Africa. They're very different results. So because daily oral PrEP is not that effective, people have continued to look at different types of administering PrEP. So we have a vaginal ring, they have a 2-month injectable. And then I was actually lucky enough this summer to be in Munich at the International AIDS Conference when they announced the results from a randomized control trial of lenacapavir. This is a 6-month injectable PrEP. So, it's a lot easier to only go to the doctor every 6 months as opposed to monthly or bi-monthly. And it was 100% effective among adolescent girls and young women. So my colleagues in the US government have said they're hoping lenacapavir will begin to be available in Eswatini in 2026. Of course, we have condoms as well, but anyone who's had the human experience of using a condom knows that it's hard to use them consistently. I have a colleague who works quite a bit in Eswatini, and she said that, summer 2020, peak COVID, she had this moment where she realized like, it's really exhausting to exist in an environment of high risk and constantly make decisions about how to protect your health. She said it made her a lot more empathetic to young women's experience trying to consistently gauge risk and protect themselves. So just to like have an empathetic viewpoint towards the ways that people take care of themselves. So the research that I am presenting today took place in Eswatini. It is the very small country outlined in red on the slide. It is inside South Africa and borders Mozambique. It's a small country of 1.2 million. The total fertility rate is down to 2.1, but still like 70% of women have unmet need for contraception. So there's some room to work there. High level of education. And then Eswatini does have the highest HIV prevalence globally at 27% of the population. That's extremely high. So 1 in 4 people have HIV. And then you can see on the slide here, among women 15 and 19 years old, 7% are HIV positive, and it almost triples 5 years later among women 20 to 24. So you see that is at age time when they are at really high risk. I note that 90% of young women have access to or own a phone because we're doing a phone survey, and it's important to know what is the phone ownership among your target group so that you aren't just overwhelmed with bias in your results. And then this small image on the slide, ooh, do I have a laser? Kind of. The small image on the side, you can see there's been almost 100,000 PrEP initiations, of which only about 250 have been not oral PrEP. So it's predominantly oral PrEP. And I asked my colleague, the Ministry of Health in Eswatini, is PrEP widely available? She said yes, because HIV is so prevalent. All health facilities have ARTs, antiretrovirals. And so it was very easy to integrate PrEP into those health facilities as well. So now that I've told you about the problem and the location, why are we doing this study? To look at HIV protective patterns. So little is known about the dynamics of HIV protective behaviors, because think about it, when you're a young person, you're sexually active, it's hard to do a retrospective recall in the past 3 months. Did you use a condom every single time? When did you, when didn't you, like what's going on? So we don't have a lot of information about how people are using condoms and PrEP together, but that's how people are protecting themselves. And also most of the studies about PrEP in Africa, especially Southern Africa, are clinical trials or cohort recruited from health facilities. That's not to take anything away from those studies. They're very important. But having a population-based study where you're looking at people who are using PrEP, not using PrEP, and able to compare them and interviewing them during their daily lives gives you some different insights. We're particularly interested in our results because the HIV community have embraced the idea of prevention effective adherence. So it's the idea that you don't have to take PrEP your whole life. You need to take it when you're at risk. So we're able to, with the study, see if people are adhering to prevention effective adherence. Also, our study will help people understand if the metrics of PrEP adherence, persistence, and continuation are working for young people. Spoiler alert, it's not, but we'll be able to tell you why not. And then here's just an explanation of why improving our understanding of PrEP use will be important to inform monitoring and evaluation of PrEP programs, et cetera. So how are we going to achieve all these goals and get all this important information? So I am part of a study called the Dynamics of Contraception in Eswatini, DICE. We have a great comms manager where I work who came up with this acronym. And it's women aged 18 to 24. They participated in a nationally representative survey in 2021. We called them back 3 years later. And I'll tell you more about what we asked them every 2 weeks. And as some of my colleagues, particularly in the room, know, mobile phone surveys are an innovative way. And it's a good way to get high frequency longitudinal data. This is intensive longitudinal data. Imagine someone calling you every 2 weeks and asking you for 2 years. Like we ask like relationship satisfaction. If you had to like report your relationship satisfaction every 2 years, your pregnancy desire, your contraceptive use, like it's a lot of information. And we really appreciate the young women who are participating. With our study, we have a great technical working group. ICAP, the Global Health Center that I work for at Mailman, has been in Eswatini for over 20 years. So we have a great relationship with the Ministry of Health, who we meet with monthly to guide the study. So what are our study objectives? I have 3 of them, and I did a little subtle foreshadowing, as you say on TikTok. So first, we describe PrEP and condom use patterns among a population-based panel. So what does it look like to use PrEP and condoms among these young women? Second, we identify HIV prevention behavior groups, and these are the 4 groups that we come up with, which this means nothing to you currently, but by the end of the presentation, you'll understand what's happening in each of these images. And finally, I want to present the characteristics associated with each of these HIV prevention behavior groups. All right, so as I mentioned, we recruited our sample from a population-based study that took place in 2021. It was called SHIMS-3, and it's a pretty robust study. There's over 200 questions on behavior, knowledge, demographics, and we do test each and every person who consents for HIV. So anyone who was 18 to 24 years old in 2024, female, provided a valid phone number, and consented to follow up was recruited for our study. And then we called them for like 17 days in March to April 2024 and asked them a pretty large number of questions. A lot of the questions are from SHIMS-3, so we're able to use that as a baseline. And then we asked them if we could call them back every 2 weeks for the next 2 years. And you'll see on the next slide, actually, most people said yes, which was great. And then we also have some bi-monthly modules. So we thought that it would be more interesting for participants and the interviewers if we add in some extra questions. So every couple of months, we ask about like youth-friendly services or reproductive health knowledge, stuff like that, that we create with the Ministry of Health. So here's one of our 2 interviewers, Peely on the right, calling about 1,000 people, or not 1,000 people, but placing 1,000 calls. So it took 17 days to call this sample of 794 participants. If somebody picked up the first time, great. If not, we called them up to 5 times. And we ultimately had 326 women complete the baseline, 97% consented to biweekly calls. So we enrolled 40% of the sample. We were hoping for a little more, but like, I don't think I was being honest with myself. It's really hard to get a hold of young women, and especially 3 years later, but I don't know, I was optimistic. But it's fine, we're very happy with the 321 women, and 314 of them are still in the study. So I'm going to play this short video that our interviewers made in just a moment, but just to give you an idea, once we completed baseline, we started calling them back every 2 weeks. We call them from Thursday to Monday. Each interviewer has about 160 women. They know them very well by now, which has some pros and cons we can talk about in the limitation section. We monitor in real time, and we use Survey CTO, which has worked really well as a way to manage our calls. And participants get 50 cents if they participate in one call and $1 if they participate in both. So let's hear from our interviewers about a day in the life as an interviewer.
Good morning. It's a bright morning and we are making our way to work, and upon arriving at work, we greet our colleagues that we find outside and we have a chit chat while we make our way to the office. And upon opening, I remove our notebooks, our earpieces, and our tablets, which are our primary data collection tool. And then before data collection begins, my colleague excuses me because we value confidentiality when collecting data. I like to begin my day with a hot cup of coffee, which I get, and then I settle down and begin assembling. On the other office, my colleague has already begun, and she's also numbering her work and organizing it according to the dates and the outcomes of the calls that she's about to make. And she has her standard operating procedures on and job aids on her table, just to make a quick reference on. And she has already began collecting the data and entering it into the into the tablet. So as she does that, she documents the outcomes of each calls with a red pen if the client was not available, or there were any other communications, or they need to make a follow-up call. So I continue with my data collection and I also document my outcomes of the call. And there's a client that's set to call after lunch, which now is about lunchtime, and my colleague switches off her tablet so that we make our way to lunch. And we like to ensure that all our study material or documents are kept safely and are password protected, which is why we put away our notebooks and tablets. And it's lunchtime. We are having lunch, and she found me still working, so I had to wrap that up. And we have lunch, and we are done with lunch. It was a quick lunch, and then she excuses me again. It was almost the end of the day because this was my last participant for the day, and I had to wrap up everything and put it back into the cabinet where we got them. And my colleague also comes over to hand over her working material, and we lock the cabinet again. We lock it in the morning and lock it in the evening. Then we wrap it up and we are done for the day, and we lock our office and we return the key to the office we got it from, again retained into a lockable drawer. This marks the end of the day, and we say our goodbyes to everybody in the office. And we had a productive day, and we hope you enjoyed. Bye.
So these are great interviewers, Peely and Waitu have been with us through since baseline, and we hope that they'll stick with us through biweekly. There's a lot of locking up of things. There's actually like another 2 minutes I cut out of just like them locking and unlocking things. They're very good at the safety. I also love they were fully branded in ICAP gear. So I appreciate it, but they're really amazing. They're the ones who are doing the hard work. One of them is a midwife actually. And so we've had to work a lot with her to make sure that she's not giving like too much information. Like we were totally fine with her responding to participants' questions at the end of the call, but my brain is nervous about panel effects, but we'll get there. So what does response rates look like? There has been a slight downward trend over the 13 fortnights, but we're very happy with 75%. I did a weekly phone survey in Lesotho for 26 months, and our average response rate was about 75, and we've sustained the 75% through a couple of weeks that are not on this graph. So what are we asking them about every fortnight? We ask sociodemographics, like how much money did you make or receive in the past 2 weeks? We ask where have you been? Where have you spent most of your time in the past 2 weeks? We also ask, do you want to get pregnant? Are you currently pregnant? We ask, are you currently using any modern contraception? If yes, what kind? We also use data from previous weeks to ask the question. So if someone told us 2 weeks ago they're using an implant, we'll ask, are you still using an implant? We ask about relationships. You told us 2 weeks ago you had a boyfriend with the initials JB. Do you still? If no, we do a partner inventory. We ask, have you had sex in the past 2 weeks? By sex, we mean when the penis enters the anus or vagina. We have one participant who has a female partner, and so we just try to remind her that we are looking at heterosexual like sex. We don't want to like delegitimize her experience, but for our study purposes, we're looking at men and women having sex. If they have reported sex, we ask about condom use, and then finally, anyone who is HIV negative, we ask them if they've been tested in the past 2 weeks. If yes, what were the results? We ask about risk perception. How likely is it you think you were exposed to HIV in the past 2 weeks, and then we ask about PrEP use. Fortnight is not a term I used a lot before this study, but I use it a lot now, but it is not Fortnite, the video game. Fortnite is a 14-day period. So just to clarify that. Finally, we'll get to our analytic sample. We have 13 fortnights of data. So from April to September of this year, we excluded women living with HIV as they're not at risk of HIV acquisition. We excluded those who participated in less than 50% of survey weeks, even though I do use multiple imputation in this analysis. We felt like there wasn't enough data to actually impute well. And then we, of course, excluded our one participant with a female partner. So I'm going to explain sequence analysis to you in 3 slides or so. As I mentioned, it's primarily used in sociology, but I'm seeing it increasingly in public health. It is a data reduction technique for classifying longitudinal experiences from a pattern-based perspective rather than a variable or event-based approach. So I gave this presentation to a friend as a run through, and his first question was like, why don't you just do a latent class analysis? I was like, well, I asked myself that as well once I did it, but a latent class analysis is the variable-based approach, right? So it's looking at what are the characteristics of these people in this group, whereas a sequence analysis is asking what is the pattern of events unfolding over time. So it's a different approach to looking at longitudinal data. So again, it answers the question, how do processes of categorical states develop over time? And your goal is ultimately to create meaningful clusters of sequences. So this is an example of what the data would look like for 3 people. These colors mean different things, which I'll tell you shortly. So there's 3 steps, and I'm going to explain each of the 3 steps. So the first step is to create sequences, but to create sequences, you have to put everyone in a state. So all my 237 participants have been assigned one of these 5 states for each of their fortnight periods. So I'm going to explain how we came up with each of these states. First, we ask, as I mentioned, we ask everyone, have you had sex in the past 2 weeks? And we ask anyone who's HIV negative, have you taken PrEP at all in the past 2 weeks? So if they say yes to both, they're in the yes PrEP, yes sex group. If they've taken PrEP, but not been sexually active in the past 2 weeks, they're in the yes PrEP, no sex group. Next, if they haven't taken PrEP and they haven't been sexually active, they're in the no PrEP, no sex group. Then it gets a little more complicated, but I'm sure we can follow. If someone says they're sexually active, then they say, yes, they used a condom during any of the times that they had sex. If they said they used a condom each and every time, then we put them in the no PrEP, yes sex, used condom group. And then our 5th and final state is if someone said they had sex, they didn't take PrEP, and then they're not using a condom consistently or at all. So anyone who said, no, I didn't use a condom during any of the times they had sex, or I only used a condom most or some of the time, we put them in this 5th state. So this is ultimately what we come up with. This is just a sample of 10 participants. We put each state together to create a sequence, and you can already get some information from the slide, which is the most, you can see that green is the dominant color in the slides, and that is the no PrEP, no sex group, which is true for the larger population. But this is what we are creating in sequence analysis, is a visualization and a grouping of people by sequences. So we get to our second step. After we've created our sequences, we get to our second step, and it is optimal matching. So the next step is to assess to what extent sequences are different from each other. And the goal is to quantify how similar or different 2 sequences are by calculating the minimal cost of transforming one sequence into another. So how can you transform a sequence? You can add a state, you can remove a state, or you can replace a state. So for example, I could tell R, I want to only add a state, and then it would, add all of these would become green, and then they would match. And there's a cost associated with each of these operations. And you, as the researcher, decide what should the cost be. It depends on your research question. So I was interested in how much time does somebody spend in a state. I want people who spend a lot of time in the same states, in the same group. So I chose duration, but you can emphasize ordering or timing of events. So it just depends on your research question. So you have all these groups, you compare how similar or different they are by transforming them, and then you create this distance matrix. So you can see that like 3 versus 2, the cost of transforming was 1.5, whereas the cost of going from 3 to 1 was 2, because there were more changes that needed to be made, as an example. So first you create the states and sequences, then you compare them and create this matrix, and then finally you do the actual data reduction step. So we have our matrix of dissimilarities, and we use this to combine sets of sequences into meaningfully similar groups, because our goal is to identify meaningful clusters. And this is a little bit like latent class analysis in that you have standards of cluster quality that you use to decide how many clusters you want. Also similar to latent class analysis in that you, the researcher, decides how many states you want. And this is a dendrogram. I don't know if we're from, dendrograms were new to me. I don't know if they're better known, but we used the Ward method, which is an agglomerative hierarchical strategy that begins with a set of clusters that each contains one sequence. So you can see here we've got each sequence is one cluster, and then they're slowly putting the clusters together that are similar. You can kind of look at this dendrogram and cut across and say, what is a meaningful number of groups that still has as low of a dissimilarity threshold as possible. So yeah, the last step is just creating the clusters. We're finally at results. So we're going to start with, again, describing PrEP and condom use patterns, and then I'll share the sequence analysis results. So of our 237 women, what do they look like? Most of them were aged 21 to 24, which is too bad. We're a little underrepresented 18, 19-year-olds, but we'll still have meaningful results. About half have given birth, half haven't. 89% are in any sort of relationship, of whom 8% are married. 32% are using modern contraception other than condoms. And then we look at some data from the baseline. 18% don't know their partner's HIV status. 80% know their partner is negative, and 2% have a partner living with HIV. And then kind of conversely, 88% of participants' partners know their HIV status. This is all self-reported. 53% have been paid for work in the last 7 days. And then 57% are living where they completed the 2021 survey, meaning that they haven't really moved in a meaningful way in 3 years. So let's learn a little bit about what this cohort is up to. So this distribution of sexual activity over the fortnights matches what we know about youth. They're not like having consistent sex. Again, the question was like, in the past 2 weeks, have you had sex? If they said no, they're considered not sexually active for that 2-week period. 19% haven't reported any sexual activity in our 13 fortnights, and most have reported between 1 and 3 fortnights of sexual activity. So that's it about sexual activity. Let's talk a little bit about condom use. Here are the 3 questions we ask. I think you've seen this one already. Did you use a condom during any of the times you had sex? If they say yes, we ask how consistently did they use a condom? We also ask about condom use at last sex. So what did we find? Condom use was reported at least once in the past 2 weeks for 54% of interviews. So I pulled all the data from the 13 fortnights. And then of the 54% who said they had used a condom, 52% used a condom each and every time, 12% most times, and 35% sometimes. So I'm very glad we asked this question about condom use consistency, because my results actually vary quite a bit depending on how I group these people. We also see that condom use at last sex is probably overestimating condom use, as 78% of participants said they used a condom last time. It's like, you ask someone like, did you wear a seatbelt the last time you got in the car? It's like, yeah, I mean, it was actually an Uber and I didn't, but like 99% of the time I do. So kind of makes sense that we see this over report. So ultimately looking at the consistency question, we see that within a survey period, 28% of sexually active participants are using condoms consistently. When we look at trends across time, because we have up to 13 fortnights for each participant, we can see what's happening. We can see the temporal ordering of condom use and non-use. So overall, 80% of our sexually active participants used a condom at least once. And I did look at people who reported ever using PrEP and not, and there was no difference in condom use, which was interesting. 82% of condom users had condomless sex at least once, and then 25% of our participants reported sex with a condom, followed by sex without a condom. So going from protecting themselves with a condom to then having sex without a condom. That gives you an idea of the condom use patterns. Now we can look at PrEP use patterns. So overall, 1 in 5 of the young women in our panel have reported PrEP use at least once. The mean fortnights on PrEP is 4 out of 13 fortnights, and the median night is 2. So this is all in response to the question, have you taken PrEP at all in the past 2 weeks? We don't actually ask how consistently did you take PrEP, or did you adhere to it as prescribed. We might add that in the new year when we go in for a renewal, but I still think we have a pretty good idea of the cycling that exists, but it would be good to have some of that further detail. So what does the distribution of PrEP use look like? So 54% of our ever PrEP users only persist 1 or 2 fortnights of PrEP use. So 54%, half of the sample, is like getting off of PrEP very, very quickly. We see that 33% are persisting on PrEP between 3 and 8 fortnights, and 12% 9 to 13 fortnights. So only one woman used PrEP all 13 fortnights, and she actually spent most of her time using PrEP and not being sexually active. So we see that there is very low PrEP persistence. So a little bit more about PrEP persistence. Over 13 survey weeks, 98% discontinued. And then we can also see cycling. So 24% of people who ever used PrEP had a gap where they stopped and then got back on, which could indicate some trying to like align risk with PrEP use. 11% had one gap and 13% had two gaps. And then again, thinking about taking the whole effort to get on PrEP, take PrEP, and then having like a serious exposure, 25% of ever PrEP users reported condomless sex at least once after using PrEP. So my first objective was to describe PrEP and condom use patterns among this panel. And we see that 28% use condoms consistently in a fortnight, and then 1 in 5 have ever used PrEP, 98% discontinued, and 25% started and stopped. So some cycling in this group. And this, I think, is data that is describing like in detail these young women's lives. It isn't available in other ways because it's hard to get that high a frequency of data. So we'll talk more about the implications of that in the discussion. So now finally our sequence analysis results. As I mentioned, I did do multiple imputation to help reduce with the missingness. About 10% of the data was missing. Most of it was internal missingness. It wasn't like the beginning or the end of the study. It was just throughout. So we have to assume missing at random, etc. But this is our visualization of how these young women spent their time. So this is the imputed data. That's why it's 237 times 5. We made 5 data sets. And what you see is that most people are spending time in the not having sex and not using PrEP group. So again, you can see that each color aligns with a state. And what you're looking at is individual level data. So when you go across the x-axis, you are going from fortnight 1 to fortnight 13. And this is like what the data would look like if we popped it out and looked at one person. This person spends a couple of fortnights not having sex, and they go to having sex without a condom, then 2 fortnights using a condom, etc. So that's what you're looking at here. This is the same data. Now it's just sorted by the state. So putting all the similar states together and then seeing how people move across time. So again, you can see that people spend most of their time not having sex, or I think the second most predominant color we see is that sherbet orange. This slide is going to actually tell us the proportion of time that these young women spend in all of the states across the 13 fortnights. And we actually see that there's not a huge variation in time spent over the 13 weeks. Let's start at the top of the graph. 7% of the time, young women are not using PrEP, having sex, and using condoms. They spend over twice the amount of time having sex without a condom. 69% of the time not sexually active. And then moving on to the 2 PrEP states, 2% of the time they are using PrEP and having sex, and then twice as much, 4% of the time they are using PrEP and not having sex. So this isn't the sequence analysis results yet. This is just like describing what's going on in the group. I'll talk a little bit about the states that are on the slides, and then I'll show you the groups that we created doing like the cluster analysis. So we had 40 participants who were only in one state. There's a lot of things you can look at with sequence analysis, like the mean time in each state, the transition probability to different states. But this is the one measure I'm going to share today. So all the participants who were only in one state, those are people who didn't have sex at all. Nobody stayed in any of those other states consistently. People who were in 2 states were switching between not sexually active and sexually active without PrEP. Those who were in 3 states, most of them had sex without a condom at least one survey period. And then those who were in 4 and 5 states were like moving around quite a bit in those groups. So we'll finally get to our sequence analysis results. What are these groups that we came up with? Again, looking at our dendrogram, looking at measures, and also figuring out what is meaningful to our analysis. And it's a lot like latent class analysis where like I got to name these groups. We've tried a lot of different names or a lot of different iterations, but this is where we're at right now. So the first group, the top left corner, is the Group that has protection by being less sexually active, and this is 64% of our participants. So you see they spend about 75% of their time not having sex. And this is proportion on the y-axis. I'm going to show you on the next slide that individual level data for each group. Next, we go to the group that has the least time protected. So we see that sherbet orange is having sex without a condom. That is 13% of all participants. We move on to the group that is actually using PrEP pretty consistently. It's around 50% of the time. Again, the blue is PrEP and not being sexually active, but they are using it consistently. And then we have 16% of our participants who are not having sex at all. So this is the exact same data. We're just looking at the individual level now. And the colors that are predominant in each group kind of explain what's going on: less sexual activity, more sex without a condom, PrEP use, and then most time protected. I thought about calling this like the chillin' group, but I didn't have a good name for the other groups. We also talked about because we're talking about protection, we wanted to keep it consistent. So my second objective for this presentation was to identify HIV prevention behavior groups based on sexual activity, condom, and PrEP use patterns. And so in summary, these are the 4 groups that we came up with: the most time protected, least time protected because they're having sex without a condom, and then 2 groups that have some protection, one from PrEP and the other one from just being less sexually active. So I want to talk about what's associated with being in a group. And these are the differences that were statistically significant. And it was interesting, age was not, but all of these there, except partner status, there were differences. And I think help us understand why we care about what these groups are. So I'm just going to compare those who are using PrEP with those who are not sexually active, because those are the big differences. And these are kind of the in-between groups. So you can see almost 50% of those who are not sexually active at all in the 13 fortnights are in school, compared to only 11% of those who are using PrEP consistently. And again, you see a big difference between those who are using PrEP consistently and those who did not have sex in the 13 fortnights. 67% of those who are using PrEP are also using modern contraception. And among those who are not sexually active in our period, only 16% were using a modern method. Next, we look at purity. 83% of those who were in the PrEP protection group had given birth, compared to only 29% of those who were not sexually active in the 13-week period. Again, that group, it's not that they've never been sexually active, it's that they weren't during the time that we were interviewing them. We also see big differences in the type of relationships based on the group that they're in. So among those who were not sexually active in the 13 fortnights, none of them were married and 42% were single, compared to the PrEP protection group where 72% were in a relationship. Actually, I was really surprised by this. 28% were married. So that is a lot more than the overall population. Actually, I think it was said it was 8%. So that's something I think it would be interesting to dig into a bit. Finally, we look at partner HIV status, and we see that there's actually not that many differences by group. There's just not that many people that had a partner that was positive. Most people knew their partner's status was negative. And we asked the question in a way that was did you test together or separate? So we get an idea of how deeply did they understand their partner's status. So again, my third objective was to present characteristics associated with each HIV prevention behavior group. And if you look at the sequence analysis literature, what people usually do is a multinomial logistic regression. And they tell you what is associated with being in each group. My mandate is to give data that is useful for the Ministry of Health. I don't know if anybody's done a multinomial logistic regression or had to digest it, but it's not really easily digestible. And I feel like our findings are clear enough. So I didn't do one. But again, you see the most time protected versus the PrEP protection group. These are really, really different groups. So the most time protected, they're in school, they're not using modern contraception. Most of them don't have kids and they're not married, they're single, whereas the group that is using PrEP are not in school, they're using modern contraception, they've had kids, and a lot of them are married. So we see some really big differences, and this descriptive data, I hope, is helpful to the Ministry of Health. So we're moving on to the discussion section, and I'll talk through the study findings. So again, looking at each of the 3 objectives, we described PrEP and condom use. We see PrEP uptake is low, which I guess 1 in 5 I think is low, but maybe In other contexts, it's not, but we do see that there's very low persistence of PrEP use. Again, they spent 6% of their time overall on PrEP. It spent more time on PrEP and not having sex than on PrEP and having sex. So it shows that young people are really struggling to get the risk period and the protection aligned. We did identify 4 HIV prevention behavior groups as listed on the slide. And then we do see these characteristics associated with each HIV prevention behavior group, with schooling, contraceptive use, parity, and relationship type tied to time protected. So what are the public health implications of our findings? Again, if we want to inform monitoring and evaluation of PrEP programs, how can we do this? So we are providing an example of how it's difficult for young women to align HIV protective behaviors with their risk periods, and that they're also using PrEP for a very short amount of time. I would really like to know why they're going off of PrEP. We don't ask them that. I'm putting in a grant to do that, but we don't currently have the funding or the time to do a qualitative aspect, but we would really like to do that. Is it side effects? Is it risk perception? Is it stigma? Is it any number of things? So it would be really helpful to know why they're cycling on and off so much. We see that PrEP uptake overestimates PrEP use. I think PEPFAR is really into uptake, but given that 98% discontinued within 7 months, we see that that is going to grossly overestimate PrEP use. And then we think that our results can inform HIV prevention strategies by showing the differences in each group. And I'm also particularly interested to find out about PrEP and modern contraceptive use because it was so high among the PrEP users. And again, with the research we're doing, we can look at the ordering. Is it that participants are using PrEP and then they are going and getting modern contraception when they're at the health facility, or is it vice versa? I think it's probably the latter, where they are on modern contraception, they are actively engaged in the healthcare system, and then they're getting on PrEP. There's not a lot of research on integrating PrEP into family planning. There's a lot more research on integrating family planning into HIV, but it is a group that it should be at high risk. If they think they're at risk of pregnancy, they would be at risk of HIV. So I would like to learn a little bit more about that. So I think the results are most useful to figure out where can we identify adolescent girls and young women at risk of HIV acquisition. So if we want to, like, what we want is for these people in these groups to move into the PrEP protection group. I mean, people are not going to stay in the not sexually active group. Like, they're going to transition to a different group. And I'm actually curious to, because we're collecting data for 2 years, I'd like to look by quarter and create the sequence analysis group by quarter and see how people move from one group to the next. Like, are they going from most time protected to less sex to protection via PrEP? Like, I don't know how they're moving across these groups, but it would be interesting to see that. But more so thinking about where do we find people at risk of HIV acquisition. So these, again, 50% of people who were not sexually active in our 13 fortnights were in school. So like school-based approaches that can be honest about, like, you may not be having sex right now, but like in the future you might. That would be I think an effective public health program. We see those who are less sexually active, more of them had kids, so they could be reached at the ANC, and then the least time protected had kids and also were using family planning. So this helps us figure out where we can identify groups and like what their behaviors might look like so that we can like reach them where they're at, as people have all different experiences throughout life. All right, so my second to last slide, we have a couple of limitations. I'll start at the bottom, actually. So sequence analysis results, the generalizability is limited to the population you're working with. I do think that the findings can be interesting in looking at maybe quartiles of time protected. And sometimes I wonder, should I just have divided people into quartiles of time protected rather than doing a whole sequence analysis? But I can take the pattern that showed up and apply it to other groups, but it is somewhat limited generalizability. I kind of talked about earlier the reasons for changes in PrEP use. We don't really know why they are either cycling or they are discontinuing so quickly. That would be helpful, I think, for the Ministry of Health to know. Again, we're talking to women who are ages 21 to 24. We do see that, a variety of experiences, with some being in school, some being married, but it would be nice because, as you saw in one of the earlier slides, by the time they're 21 to 24, 21% are living with HIV. where it's only 7% among those 15 to 19, but it's hard to get a hold of them. I mentioned earlier in the presentation as well, the measurement of PrEP is coarse. We're only asking, have you taken PrEP at all even once in the past 2 weeks? It would be great to know more about adherence. That would give us a better idea. But even with the results as is, we can see that there's a lot of cycling. And so we could only imagine like we're overestimating like how well people are using PrEP. The panel effects already came up. You know, the study in the US that this is based on, the relationship dynamics and social life study, they did a lot of research about panel effects in that study when it was fielded in 2010, and they didn't find panel effects. However, Eswatini is a different setting than Michigan. It is harder to like get information. I mean, most people have like internet connection, and there's a lot of people have smartphones, but imagine again yourself, if you have like a health expert calling you every 2 weeks to ask you questions, you might start being like, well, what kind of PrEP like is available? And that could be, it's like, it could become sort of an intervention. So we actually ask our interviewers at the end of every call to mark whether or not they gave information or advice to try to track how much it's going on. And again, our lovely midwife, we're really like trying to have her like keep all her medical knowledge unless it's requested. Again, we don't want to like withhold information. And then finally, one of the next analyses I want to do, because again, with sequence analysis, you create the states. And one of the states I want to add in is a new relationship starting or a relationship ending, because then that might explain some of the patterns we're seeing. And we have people reporting relationships starting and ending, but it was funny, like a couple months ago, my interviewers were like, ABBA, because I talk to them every 2 weeks. It's like my favorite call of the week because they have a lot of like deep information. It's nice to actually talk to people like doing the work. They're like, do you know what a situationship is? And I was like, I do. So a situationship is like when you have like a casual sexual partnership that's like, it's just like convenient. They're like, listen, you want us to ask these participants all sorts of questions about their situationships. They don't know really that much about this person. They don't know how many kids they have or like, what is their high school education? So they're like, you really need to like adapt the survey so that people can report more casual sexual partners. So we were able to do that. And that will give us a better idea of how relationships are impacting the work. So that's all. Thank you very much for your attention, and I look forward to your questions. Yeah.
Wondering why the sequential analysis was focused on the duration of the state and not something else. And so, if you like, what would it have looked like if you focused on the states changing? What results would that have created?
Yeah, it's a good question. So I chose to have it focus on duration, and you're asking if we looked at like one thing we could have done is to tell the algorithm that anytime someone has like unprotected sex, to like make that have a high cost, so that people who use PrEP or use a condom and then don't use a condom basically would be grouped together. So I don't know what it would look like, but it's a great question. And again, you can really drive the sequence analysis based on what you want to find out. Do you have an idea of what you think it might look like?
No, I just mean like what are the implications of looking at like the states changing rather than direction?
Rather than direction?
Than duration.
Than duration. Yeah, there's, again, it's up to you as the researcher to take a look. The applications of sequence analysis I see often are looking at family demography and figuring out like among generational cohorts, how is the time spent cohabiting before marriage, before children started, so heteronormative, but that's what they do in the analysis. So people ask the type of questions you're looking at. For our work, we wanted to really understand the duration. Yeah. Yeah.
Do you mind standing with the microphone on the board? Can't hear you so well. I don't want them to miss your answer.
Important stuff.
Thank
Yes.
you.
Thank you. Yeah.
Just Islam Ahmed, I was reflecting on your thoughts for that. There's always been like a tendency to integrate family planning into HIV programs, opposed to actually integrating HIV within family planning. Do you think that is more like the way funding is being channeled that is influenced? Because I'm like thinking of it, family planning is a program, and then like most of the people who come from family planning are sexually active, so it would make sense
Right.
to actually have the PrEP program sit
Mhm.
there.
Yeah.
And also with this stigma and all, like
Mhm.
people are coming, so people can have like integrating this would be very beneficial.
Mhm.
PrEP violence.
Yeah.
But why do you think that is not?
You know, one of my colleagues, I was saying, writing a grant, and I want to look at, you know, how young women perceive HIV versus how they perceive pregnancy risk, because it seems to be quite different based on their behavior. Like people are better at taking action to use contraception rather than PrEP or condoms. And she's like, you can do that, but like most of the money right now is not going towards that. She's like, you know, family planning is a more touchy political point, unfortunately. So she's not particularly encouraging. I'm still including it as one of my aims, but yeah, the literature looking at integrating PrEP into family planning programs is not particularly robust. There's more of a literature that says like we should do it. Like people are like, this makes sense, but people are not really doing it yet. And the integration of family planning into HIV programs also took a very long time, and like I don't know how profound that is at this point, but yes, it makes sense to me as well. So we'll see. Yeah, Tom.
I have a really great job.
Thank you, Tom.
Yeah. So my question is about the types of PrEP that exist in Eswatini
Mhm.
and understanding that 2-for-1 PrEP and long-acting injectables are becoming more common. I'm curious, just what the landscape is in Eswatini and if that's going to be changing.
Yeah, it's like 99% of people are taking oral PrEP. And then the vaginal ring and injectable PrEP is rolling out. And then they think lenacapavir will be available in 2026-ish. Yeah, that was the word on the government street. So yeah, I think I mentioned PrEP is pretty much available in all health facilities in Eswatini. Yeah, thanks. Yeah, Cynthia.
Terrific job.
Thank you.
Thanks for being here. So I was curious about sort of the comments that you may have received from your partners on the ground, in the Ministry of Health or in some of the clinics. Were they surprised at the rate of cycling? And I'm wondering whether or not sort of any topics around reproductive coercion possibilities came up as possibly contributing.
Yeah, we haven't asked about reproductive coercion, but we do have a module about that. And like 4 months, it's like, if you were to get pregnant, who would like make the decision about what you would do? So we have some of that forthcoming, although it's not tied to HIV, that like in PrEP use, that would be a good question. I think my Ministry of Health colleagues, I don't think they commented on the cycling, but it would be worth asking. Yeah, great, thank you.
Thanks.
I don't know, Celia?
Thanks for the presentation. I was wondering if you could talk a little bit more about, in the beginning, you mentioned that PrEP use is not as effective in this context. And then we saw those patterns and cycles of use. Can you talk a little bit more about why you think that is in comparison to other contexts where it has been so effective?
Yeah, I mean, I think it has to do with culture. Like in the US, we love time, we love like order. We're in a culture that is like dominated by organization. And that's not to say that cultures in sub-Saharan Africa are any less, but I think that there's just a different way of moving through the day. And that would be my guess on like why it's just not organized in the same way as the US. I think there's also just a lot more structural barriers. There are definitely structural barriers in the US, but I think even more so, like one of the modules we did with the young women was asking them like, have you been to a health facility in the past year? If yes, like how did you get there? Most of them were walking, most of them it was taking them more than an hour. So it's effort. And then for those who hadn't been, we were like, why didn't you go? They're like, we're busy. Like, so again, it's kind of like with COVID, like masking all the time is great, but it's exhausting to do and you have to like make time. Imagine you have to like go to a health facility to get the masks. So I think it's like structure and culture, but I don't know if anybody else with other lived experience has any comment on that, but thank you. Did you have a question?
couldn't remember whether it was one of the frequently asked questions or not, but the risk perception, I wonder if you had looked at that in relation to where people end up in these groups, or when there are episodes of PrEP use in the context of sexual activity, you know, you have their HIV, potentially their partner's HIV status, but I wonder even above and beyond that, risk is
Yeah.
really driving
Yeah.
the PrEP use and condom use.
Yeah, I think that's, I have a postdoc who's like loves risk perception, who will be looking at that in the data. And so, but we have looked and it's like only 5% of the time do people perceive themselves to be high, medium or high risk. So risk perception is fairly low, especially given the context, but that would be a nice, there's a whole bunch of kind of covariates I could add into the sequence analysis. Like I could create a whole state that is like high risk perception as a state itself, or again, like changing relationships. So I can continue to build on like the patterns and the states. And I think that's like an important look, but there's a lot more risk perception of pregnancy than HIV acquisition. Yeah. Justin, did you have a question?
Yeah, thanks for teaching me about sequence analysis.
You're welcome.
In situationships, kind of work that into my vocabulary this week. I was just wondering how similar or dissimilar your longitudinal, high frequency sample was demographically, sociodemographically from your household.
Appreciate you asking, and I meant to mention that. So when we finished our baseline data collection, we compared non-respondents and those who didn't have a cell phone compared to respondents, and we had no statistically significant differences, which is one of the reasons I wanted to do it in Eswatini, because I knew there was high cell phone ownership and there wouldn't be massive differences. We're not trying to make population-based estimates, so it would be okay if not, but it's an important question when doing mobile phone surveys. I also compared our analytic sample of the 237 women with our broad sample, and there were also no statistically significant differences. So it's a good context to do a mobile phone survey. Yeah, thank you for asking. Yeah, in the back.
I want to find out within the period that we have been taking collecting the data, has there been anybody within that 237 that have been infected enough to be out of the data?
So of the 314 women who are currently enrolled, one has seroconverted, and so we excluded her from this analysis. Yeah, so I don't know what that incidence rate would look like for us, but that is what we've seen. And we asked people during the baseline survey to self-report HIV status, but we also were able to compare with what their HIV status was in the survey that did the biomarker in 2021. There's only like 3 women who were positive in 2021 who didn't self-report in the phone survey, and all 3 of them like eventually disclosed to the interviewer. So people have been pretty good about self disclosing, although I could imagine if you were recently diagnosed with HIV, it might take a little bit of time. So maybe that's something I need to like prompt the interviewers to ask someone who's recently reports like a new HIV status, like when did this actually happen? So that's a great question. Yeah. Yeah.
In terms of calling the participants, like you mentioned that the 2 interviewers would call someone up to 5 times. With that, I have a few questions. So would it be like 5 times in a row, or just 5 times Monday, like at least 5 times Monday through or Thursday through Monday? And did the participants know that if they didn't pick up the call or have the interview at least 50% of the time, that they would then be excluded and stop being called, or like did they have incentive to want to pick up aside from just the money, but like knowing that the money will then continue, like it could stop at some point, and then maybe they weren't at a point where they're like, okay, the 50 cents this time like matters a lot. And was there a way also for the participants to then contact the interviewers? So say you were called and couldn't pick up at that time, but you do want to continue participating. Could you message them in some way and just say, this day, these times work, like I would like to talk.
Totally. Yeah, great question. So during baseline, we called people up to 5 times across the like 17 days. And we really tried to vary the time of day and the day of the week, knowing some people are more available on the weekends. So that was our attempt at trying to get as representative of a sample as possible. If they didn't pick up during baseline, we tried up to 5 times, we were not going to contact them in the future. once they've enrolled in the biweekly, so it was 321 women who enrolled in the biweekly, we only drop them if they explicitly say, like, they have a hard refusal. They're like, I'm done with the survey. So anybody else, even if they haven't responded for 10 fortnights, like, we'll still call them. I don't know what percent of the sample, but a certain percent gave us phone numbers of household members and their name if we wanted an alternative way to get a hold of them. Some of them gave us a second phone number. So like, we're really trying our best to like keep up with them. And as part of informed consent, we let them know how much reimbursement they could expect. And my colleagues in Eswatini at first were like, Abba, like, you're giving people $1 a month, like that's not enough, because Eswatini is like a middle income country. But honestly, our participants, like if they do not get their incentives, I hear about it, like my interviewers hear about it, and then I hear about it. And so I don't think it's a coercive amount of money, but I do think it's a motivating amount. And they also can call our Ministry of Health co-investigator if they don't get their incentive or if they have any study issues. So they can give her a call. I think like only 2 or 3 people over the last 8 months have called her. And then yes, they can send like a beep, like a little message to the interviewer to let them know to call back. And our interviewers know our participants extremely well now. They're like, yeah, Sarah had exams, like she's in school, so like we couldn't get a hold of her. So they have a pretty good idea. And like participants, it's just a very different culture of participation in surveys in Eswatini. Like people are much, as you can see, are like much more willing. So yeah, I think it's a nice balance. I mean, they're getting something out of it and then they're getting some information. It's like a novel experience. But again, my one concern is that like, we're not just like completely educating them and making them different from the general population. But even if we are, we're still seeing there's a lot of barriers to using PrEP consistently. Yeah.
More of a comment than a question about, I actually used to work on RDSL, so when you were describing it,
Oh, great.
it sounds like RDSL.
Yes. Yeah.
But we did an analysis looking at women's risk of experiencing intimate partner violence, and we used this like within between regression model
Yeah.
to look at like the influence of relationships, so like within women, but then across relationships. And I wonder if we could do the same for like risk of not using PrEP or not using a condom, so those various risk groups. And then at least from a relationship perspective, I'm sure there's other factors that are important in this context, but something like that that could sort of isolate the woman's individual risk versus how it changes their population.
Totally. That's what I told NIH I would do, and I haven't done it yet, but that's my 2025 project is to, sorry, project 2025. That's my next year project to look at and use like mixed models to be doing that. So absolutely, yeah. Do we have time for one more question? Sure, yeah.
Looking at the least protected group that was highlighted, was there any discussion with the Ministry of Health and Foreign to see what more can be done for this particular group? Because there obviously maybe at more risk of HIV than other groups.
I am not involved in like their behavioral interventions or messaging. Like I share the results and then they take it from there. Like the one tangible thing that they like mention quite frequently is they have like a radio program. So they'll be like, oh, great. Like we'll include this in the radio program. We see that like 95% of people don't know at what point in their menstrual cycle they're most likely to get pregnant. Like I think it's true around the world, but they're like, we will share that via like, that'll be a topic we highlight in the radio program. So I'm not sure what they'll do with it from there, but yeah, it's a good question. Great. Thanks everyone for the great questions and for your attention. I appreciate it.